So the purpose of today is to go over kind of what social determinants of health are, why they matter, talk a little bit about my program of research, and ways to leverage existing data to look at social determinants. So social determinants of health are informed by our cultural norms, our social and political agendas, and how that funnels through to our policies. They impact health through a variety of different mechanisms, but they are the conditions that people are born into, grow, they work, live, and it says age and play, and worship have been added as well, that impact our health and quality of life outcomes. And while they are just one layer of determinants of health overall, they're certainly an impactful layer because they impact not only access to healthy resources, but our ability to navigate society, our decisions and choices that we make daily, and really just our lived experience. These go on to include our ability to make healthy choices and our ability to live high quality of life. We'll get into how marginalization and kind of stress impacts us in a little bit. So social determinants of health, they don't just exist innately. They happen because they're a reflection of our social and cultural values, or at least the cultural values of those in power. They reflect the distribution of power in society, and they reflect historical racism and other discrimination towards marginalized parties based on our social views. And again, not everyone's views clearly, but the people in power that have this is reflected in our policies. So these social determinants and the rules of our societies create social stratifications that end up with health inequities. And again, the pathways to inequity does have a trickle-down effect, or I should say trickle-up effect, from our political and social agendas to our laws and practices, how that's manifested within our formal and informal systems in society, how it propagates inequities among marginalized parties or continues to support those that are, I guess, better off within working the system. And it ends up affecting the individual level socioeconomic status and the outcomes thereafter. And that slide has a lot on it. So because these are socially placed policies, you have overlapping vulnerability based on socially placed marginalization. So whatever the culture values or doesn't value at the time, according to people, can be based on sexual orientation, race and ethnicity, gender and sex, ability or disability. My work is in HIV, so I have that, but there's certainly many other stigmatized conditions. Geographic location, and more specifically, not just access to care, but kind of culture within that. And then even stigma towards poverty itself.
Dr. Wise,
yes.
Do you mind trying to angle the microphone a little bit?
I'm quiet. Sorry, thank you. So when you had the Affordable Health Care Act enacted, one of the things it did was incentivized to incorporate social determinants of health into healthcare practice. And you had research come about that showed that really 10 to 20% of health inequities are related to the healthcare system itself, and that about 80% of health inequities can be attributed to the upstream impact of social, environmental, and economic stressors. And we'll kind of go through the pathways that happens. But it's not just access to the material circumstances, it impacts our psychosocial context, our biologic and physiologic responses, and the behaviors and choices that we make on a daily basis. Again, these are not the only inequities that it results in, but they are the ones that are related to each other and that is evident in my research, including cardiovascular disease. That's the #1 cause of morbidity and mortality among men and women in the United States and really in the world. And we'll talk about it more as we go on, but mental health and depression, anxiety, and stress are now really demonstrated to be highly associated with risk for cardiovascular disease, as well as these other risk factors leading up to that. So again, our policies shape our social determinants of health. And our social determinants of health are access to economic stability, our neighborhood and physical environments, our education access, access to food and clean water, healthcare system, and our social and community context all influence the choices we make on our daily basis, the daily struggles or not that we go through, and really just our lived experiences throughout life. Someone that doesn't live in a safe environment can't go easily work out or can't enjoy trees to de-stress and walk around today. If you don't have access to education or good employment, that it certainly impacts your ability to access your own resources. And then just community and social context is so important to your own mental well-being, and not just functional support and informational support, but just how your quality of life is and how that impacts your physical health. So social determinants are largely responsible for the inequities in morbidity and mortality. And I know that's a very broad statement. Again, it is my research is focused largely on cardiometabolic risk and its relationship to mental health. But it is related to accelerated aging when you have adverse social and economic conditions. And again, that's due to increased exposure to the fundamental causes of disease, but also reduced access to quality healthcare and quality resources. You also have reduced adherence to measures, and those may be due to competing factors. Really, if you have food insecurity, housing insecurity, employment insecurity, you're going to be really unable to get to the doctor, maybe have to prioritize differently to meet your medication needs, those kind of things. So a little shift here, because we keep talking about social determinants of health. But if you think of social determinants in the way that you would say adverse exposure to social and economic stressors, then you have the environmental, economic, and social stressors that increase the risk for morbidity and mortality and have an accelerated effect on aging. There is psychological well-being, there are physiological response, there are changes in your genetics, and through your choices and behaviors. And the stress process model is a good model to kind of capture this. And this is used in an expanded variation because I kind of go into the physiologic manifestations of stress. So I'm going to walk through this a little bit slowly. But you have your adverse social and economic conditions at the top. And I think it's very important to capture that as not only an objective measure of low socioeconomic status through area level deprivation, residential segregation, or cohesion, right? And your individual characteristics that are reflected, like employment, education, income. But if you have a cultural context where you are consistently marginalized or consistently not getting ahead in life, and sometimes you have an internalized inferiority, which relates to chronic stress. And certainly this is not the only way that you can have chronic stress, but when you have daily struggles that you can't seem to get past and you have instability in just your normal daily lives, then this is an effect. So manifestations of stress include your psychologic, physiologic, and behavioral responses, and they'll result in health inequities, including those that I had listed earlier, such as cardiovascular disease, hypertension, diabetes, and stress and depression. Anxiety and depression, work in a little bit of an unusual feedback loop where some of the physiologic manifestations of stress can actually lead to anxiety and depression, but once they're there, they actually continue to have a pro-insulin effect and can lead to some of the other risk factors where it's a kind of hard loop to get out of. Here also, I deal a lot with people living with HIV, so you have the moderators of stress too, and clearly this isn't just HIV specific, but unfortunately is a very high psychosocial prevalence in that population. With low social support, if you have a history of mood disorders that may impact your cognitive appraisal, if you have a history of trauma, abuses, adverse childhood events, anything that's going to change your perceptions of threats in the environment is going to impact kind of what you perceive as stress moving forward and trigger these responses. And I go through a couple of different variations of this to work through the physiologic impact. So stress doesn't just exist as a psychological component. When you have a response to stress, you have a physiologic cascade that happens, and it's a protective measure the body does, but over time it produces wear and tear of the body that's generally referred to as allostatic load. One of the positive, I hate to say positive, one of the helpful things about these responses is they can be biomarkers that can actually be used to measure objective levels of stress so that you can screen for interventions, measure progress, those kind of things. So you have a cardiometabolic, neuroendocrine, and immunoinflammatory cascade that occur in response to stress. And over time, that leads to impaired glucose tolerance or diabetes. You have dyslipidemia, central adiposity, increased heart rate, elevated blood pressure. You have differences in platelet function and cardiomyopathy. Excuse me. So again, these immediate responses to stress, which are designed to help with your fight and flight response, which are designed to be helpful initially, over time produce that wear and tear, which lead to the diseases at the bottom here, including cardiovascular disease, hypertension, obesity, dyslipidemia, and again, depression and anxiety. I know all of these are not associated with depression and anxiety. That's more of an inflammatory relationship that then has a feedback loop back, but for the simplicity of the diagram, that's how I'm displaying it. And again, there's different things that influence the physiologic response to stress as well. The cognitive appraisal here is frequently manifested by somebody's previous experiences, whether they've had positive coping mechanisms and been able to be resilient in their environment, or they've had kind of continued negative environments. And it really impacts your perceived ability to deal with threats more so than an actual. And that can result in that easier triggered stress response. Okay. Obviously, and unfortunately, once you kind of get in that loop, if you have stress, anxiety, and depression, then you just kind of innately feel like you can't deal with the environment very well. These psychological responses also have a behavioral response that kind of goes bidirectional there. And the behavioral responses by themselves lead to physiological responses and inflammatory reactions, but also influence that triggered psychological response and ability. And they just kind of all tunnel together to increase the stress response over time. And these are modifiable, but unfortunately, we don't spend a lot of time with teaching people how to modify them. So just a summary slide here, but increased exposure, adverse social and economic conditions impact health disparities through their impact on stress. So American Heart Association and a couple of other entities are starting to realize how stress and psychosocial stress do impact risk for physiological health too, including stroke, heart failure, cardiovascular disease. You see all these here. And you do have the behavioral pathways, which I think in the past, most people have kind of honed in on that, is that you have like low physical activity, unhealthy diet, those kind of things that lead to increased risk. But really the physiologic pathways are now being investigated as a direct response to stress that exist regardless of those unhealthy behaviors. Okay, I'm going to kind of tell you about my program of research a little bit, and then I'll dive into more HIV specific. So my program of research is just getting started, but I look at social determinants of health among people living with HIV with a heavier focus on women living with HIV, as there is a greater incidence of psychosocial stressors in that population. More specific, I'm looking at the relationships between cardiometabolic risk and psychosocial risk factors and those relationships with mental health, and then behavioral interventions to reduce the impact of psychosocial stressors and structural stressors on risk for cardiovascular disease. And I have worked with Max Wise and CNIX as well to use some of the existing data that exists through that. And kind of when we're wrapping up, I'll talk about some of the different data sources that exist and how it's an efficient way to look at research and conduct research. So HIV by itself has immune inflammatory reactions that are related to cardiovascular disease, diabetes, depression, these kind of things, okay? But even when viral suppression exists, there's still an increased risk there. You still have a prevalence of psychosocial stressors in this population too, and it just kind of increases the risk for many immune and inflammatory disorders. And again, I summarized in here as metabolic syndrome, mood disorders, and cardiovascular disease. Some of the older medications were worse on cardiovascular risk. It's a little bit better now, but that's also a consideration too. But you do have about a 2 to 4-fold risk of many of these diseases in people living with HIV, and it doesn't go away with viral suppression. It doesn't go away if people are diagnosed earlier, those kind of things. So these are general statements about people living with HIV. Women living with HIV in particular have relative increased risk for cardiovascular disease and some of these psychosocial depression, anxiety, PTSD compared to men living with HIV. And I say relative because it's still, the cardiovascular risk in particular, men without HIV still are at higher risk, but the margin is a lot shorter. Okay. So in an age where we have early access to care and we have viral suppression and we have antiretroviral therapy that works, why do health disparities continue to exist in this population? So again, many people living with HIV have increased odds for structural stressors such as poverty, food insecurity. They have increased risk for psychosocial stressors, adverse childhood events, abuse, interpersonal violence, and polystigma. And polystigma is a term for basically layered stigma or discrimination based off your race, gender, sexual orientation, HIV status itself, where you just have kind of multiple different layers of discrimination and marginalization going. That can increase this risk for, I guess, ongoing psychosocial stress. Now, the total population of people living with HIV has about 3 times the rate of depression compared to the general population, and depending on which study that you grab, but women living with HIV experience psychosocial stressors at 4 to 5 times that rate. So the next few slides are going to go over kind of why people living with HIV may experience increased psychosocial stressors and structural disparities. This one is a map that shows HIV rates in the US and its overlap with poverty. And I want to say this was 2019. I'm sorry, I don't have it pulled up right now, but it is a relatively recent one. And you'll see that many of the areas that have poverty are also have an overlap with HIV, okay? So that's individual level poverty. It's also area level poverty and deprivation. But I think it's important to also note that structural racism and daily struggles within that also matter. There's been some recent articles that have come out that describe how areas that were historically redlined that no longer have area level deprivation, or they have relatively better resources available, you still have increased risk for psychosocial stressors and cardiovascular disease in those areas. And the thought behind it is just the daily struggles and kind of built-in discrimination that's in the lived experience there impact those. Again, racial discrimination and daily lived experience is thought to impact the lived experience and psychosocial stress. And HIV is disproportionately impacts individuals of Black and brown skin. And this is the 2019 estimated HIV infections that year. And I did break it down so you can see that you have a percents here. It's about 50% of the population that is Black is diagnosed with HIV compared to where it's just 12.5% of the population. And I'm sorry, I don't have the exact stats up there, but there's a very wide gap or it's disrepresentative. Where I would like to think that we've come a long way here, I don't think that we really have, especially in the South. And HIV disproportionately impacts gay and bisexual men. Actually, 69% of the diagnosis in 2019 or in this population, with men of Black and brown skin being disproportionately affected within that. So again, we get into that kind of polystigma, polydiscrimination area and how this might impact psychosocial stress on a daily basis. When you look at women as well, Black women are much more likely to be diagnosed with HIV compared to white or Latino women. And I think it was 11 times more likely than, here it is, it's 11 times out of white women and 4 times out of Latino women. So there's a significant disparity in the diagnosis there. And there's differences in access to care and stigmatization within cultures that also impact that thereafter. Now, transgender women and HIV, transgender women make up 2% of the new HIV diagnosis per year. Within that, though, there's a great disparity between Black transgender women and Hispanic compared to white. So again, once you get into late screening and you're looking at how to best treat people, you have to kind of look at those most at risk. And unfortunately, too, you have a very high risk for mental distress in this population, too, which goes along with the cardiovascular disease risk and cardiometabolic risk in general. Okay. So again, all these slides are just really represent the overlapping stigma and discrimination among people living with HIV, and the general population really increases the risk for stress-related disorders. Okay, and this slide here is just to demonstrate too that it has shifted, I guess, greatly over the last 10 years or so, where HIV does not as predominantly impact the South as it used to, but you still have 51% of the diagnosis occurring here. Take that into context that you have increased structural disparities, that we're not a Medicaid expansion state, or many of the southern states are not, that you have increased poverty, layered with stigma and discrimination, not only based off sexual orientation and race and HIV status, but a lot of the behaviors associated with HIV as well, such as substance abuse and those kind of things. That it really ends up with widening disparities, not only with people living with HIV, but widening disparities within HIV outcomes with that, and also the other cardiovascular outcomes kind of all bleed together within our social and healthcare systems, unfortunately. Okay. So a lot of our healthcare interventions do focus on the individual, right? They want to treat something that already exists. We're not really great at integrating social determinants of health into our systems. But to really reduce health disparities, you have to take into the larger context in which they occur. So to address social determinants of health within this, again, some of the first slides looked at the policies that affect this, and they impact our cultural values too. I think there's been a lot of talk and bringing to light lately what historical racism has done in a structural format and how to correct that. And it creates a lot of discomfort because when you have an inequitable power distribution, to fix that, it also means taking power away from other people. And it becomes a very difficult conversation to have. but to try to address those policies that propagate inequities and to get people trained in the workforce that really understand how to do that best. To do that, you also have to measure the problem and assess the impact. And I will get into leveraging existing data in just a second to be able to really take that in a multi-level approach to be most efficient too. Implementing screening in practice to meet social needs. And what this really means is screening for those social determinants of health and extending the healthcare continuum so that you partner with community partners to give them services they need and have that kind of expanded version of health and quality of life and what that really impacts and is impacted by, I guess. And then to scale up interventions to promote access and equity so that the interventions that you do have in place, that you don't have barriers in place just because of deficits in your structural systems too, that you can kind of help bridge those. And I think one of the, I don't want to say newest things, but it's to really focus on developing a workforce trained in social determinants, because it has become quite the buzzword lately, but you really don't have training in your systems yet. I'm not sure what the school of public health is. I know school nursing is just starting to integrate that into the curriculum, and the advice is to not integrate it into like single courseworks, but to integrate it throughout all of the processes. So it's really well informed in all our decision making. Okay, so on the leveraging existing data part, there's multiple layers of this. So I work with several different cohort studies, or some of them are more just clinical pool. So I'm not sure if any of you are interested in HIV research, but MaxWise is a prospective observational study that follows women and men living with HIV along with demographically matched controls. And they have a lot of psychosocial data along with clinical data that goes and is collected every 6 months. One of the things, and not all studies have this, but is very beneficial for this, is there are geospatial data available, which is just 12-digit FIPS codes. And you can connect that to census tract data and CDC data to really see the impact of these social determinants on the individual level factors and how those interact. Phoenix also has some geospatial data available, but it's at the just normal zip code levels, so it's a little bit harder to narrow in there. But you still have like kind of regional areas that you're able to see screening and like target intervention areas for those and kind of see how progress is made over time too. I know market scan's a little bit different there, but I have that in there as well. And it gives you the Medicaid and Medicare data and then insurance data available, so that you can kind of look at how everything connects within relationships and just encourage efficiency with research. They do not have any geospatial data available through that, but it does allow you to kind of look at the relationships in a large generalized portion of the American population. One thing lacking in that one would be that it does not include individuals without insurance. So that kind of that would be an important point to capture somewhere else. Not necessarily going along with leveraging existing data, but going back to the use of biomarkers as well. Stress and anxiety and depression and those kind of things are kind of lofty concepts and very subjective terms, and we have ways to measure them in an objective way. There are a variety of mechanisms. So understanding how that impacts people differently allows you to target the interventions and modify them to increase their effectiveness better. And then, I'm sorry, I'm reading my notes too. Also encouraging those of you, I know some of you are already involved in research and some of you are not, but to get involved with your working groups within the existing cohorts too. I think that complementary research interests, just kind of like writing groups can do to help efficiency there. They can really help research occur in a more rapid manner and evolve to help people do policy change.